So, panel two. I think that this panel is a great representation of organizations that are trying to work collaboratively to not only improve health and well-being of our children, but to also support them in their early learning. And this is critically important, especially for children from at-risk communities. And, you know, earlier on, the deputy mayor mentioned that, for example, firemen are considered trusted professionals. And of course, from my perspective as a program director of Reach Out and Read, I would say pediatricians and nurses are another group of trusted professionals that our families interact with. And through our medical providers, they're able to not only prescribe books, but speak to families about the importance of reading aloud to children and helping to engage our families so that they understand and can follow through on that. And that's how Reach Out and Read contributes to the success of children in school. So I give that as an example. And now I will turn over the panel to Dr. Elizabeth Isakson, who will converse with our next group of panelists and explore how they also try to support families in the community.
Hi, good morning. Oh, it's on. I usually don't need when everyone says my voice is usually loud enough, but I understand that this is for the video. So good morning, everyone. And our panel today is community-based approaches to improve health and support early learning. And I'm co-director of Docs for Tots, and one of our key concepts is that health and learning are intricately interlaced. You can't learn if you're not healthy, and lifelong health is often dependent on how you've learned and what your education level is. So never in the lifespan are they separate, but throughout the lifespan they're interwoven. And I'm really honored to have our three panelists today because they each bring a very unique experience in working in communities on that intermarriage of health and learning. And Reach Out and Read is perhaps one of the best examples of it. And I wanted to piggyback on what Monique was just saying. You know, what is Reach Out and Read? It's an educational intervention in a pediatrician's office in the context of a relationship, building on what Tova was saying. There couldn't be anything better. You're there as the physician watching the family receive a book, and you're watching that interaction of the parent opening the book with the child and flipping through it. Talk about an ability to model and to guide and to give really in-the-moment feedback, not from on high, but just, you know, in the moment of that relationship. It's an amazing intervention in a community. And in that vein, we're going to learn about three different types of community interactions that sort of weave health and education together. And we have three amazing panelists. First, we have Emilio Carrillo. Dr. Carrillo is the Vice President of Community Health at New York-Presbyterian, an Associate Professor of Clinical Public Health and Medicine at Weill Cornell Medical College. So we're very happy to have him and to learn that everything he's doing up at New York-Presbyterian. And Tanya Friedman is, oh, sorry, I went out of order. Delaney's next. Delaney Gracy is a Chief Medical Officer and Senior Vice President of Medical Affairs at the Children's Health Fund, a nonprofit organization committed to providing health care to the nation's most medically underserved children. And our last panelist is Tanya Friedman, who has worked in public education for nearly 25 years as an elementary school teacher and school leader. So how we're gonna manage this panel is we're gonna give them each about 5 minutes to talk about what they're doing right now. And then I'm going to present about 3 questions to them and get each individual's take, because I think that's a real strength of this panel. We have each unique experiences. So thanks so much, Dr. Carrillo.
Thank you, Elizabeth, and thank you, everybody, for being here and for the invitation to speak. It's been some really great discussions so far, and you know, we've talked a lot, as we should, about the child and the parent, and there is such a broader context that we need to look at when we assess for learning, reading, And it, as Hillary said, I mean, it really does take a village. It's the interaction and the collective work of so many of us in so many different fields. Of course, the firefighters, the doctors, everyone that's part of our community. So the parent and the child are in the center of an entire village that needs to focus on the learning. So in the case of asthma, let me just bring that as a case study. When you spend with your little boy or little girl the whole night in an emergency room with a wheezing episode and an asthma episode that's not breaking, there's not going to be much learning the next day. Days that are missed from school, the inability to study, the inability to focus, it's very, very important that health be there for the appropriate environment of learning to take place. So how do we deal with that? I mean, New York City, we have an inordinate amount of asthma in our communities, and it has a lot to do with the social conditions, the environmental conditions that we have in our city. We see that those areas of New York where there's greater exposure to pollutants, toxic environments, the poor areas, the areas where the most immigrants, the most people of color, the most unemployed live. I mean, those areas, we have the most asthma. And it's not a genetic issue, it's not a medical issue, it's an environmental issue. Many things that go into it, but nevertheless, the child does get sicker in these environments, and poverty is a major propellant. New York City has double the rate of asthma hospitalizations for children than the entire nation, and 3.5 times a greater rate of asthma hospitalization than the state of New York as a whole. So we have a problem, and that's a problem for the child, for the parent, and for the learning. So we need some collective impact. We need to collectively bring our resources, focus our organizations, focus our institutions, focus our resources into the problem that we have before us. How do we bring together the schools, the clinics, the hospitals, social agencies, the city of New York, state? How do we focus all of them on this particular project, a particular problem, by creating a project that we can all contribute to and make something happen? We've done that. We're doing that in Washington Heights, Inwood, Northern Manhattan. It's together with parts of the South Bronx and East Harlem, one of the highest rates of asthma admission in the city of New York, which in of itself, it's so disproportionately high. And what we've done is basically, first, if you don't track it, it's not there, you don't know it, you can't do anything about it. We do the evaluation, get the numbers, what problems do we have? And we find that that asthma is a major problem for kids. So we focus on that. We look what gaps do we have in our resources, in our services that impact. We work together with leaders in the community, with leaders of community organizations, and our own experts, as well as the academics, those in the School of Public Health, Columbia School of Public Health, and the School of Nursing, et cetera. And together we come up with, what are the strategies that we can do together as a collective impact with the community service agencies, with the clinics, with the academics? What can we do together? And we find that optimizing the use of information technology is key, so that we can develop disease registries We have the information systems capability that every child that has ever touched the hospital with a diagnosis of asthma can be put into a registry so we can track what happens to those kids. Do they come back for more admissions? Do they come back? Are they making their appointments? And then we can have nurses that can do care management, case management, and follow those kids to make sure that they're getting the proper medication and they're coming in for their checkups and they're not overusing the emergency room. We develop the treatment within the clinics to make sure that before a child comes in, we know that all the shots are done, that all the needs are met, and we pay attention to the cultural competency. Again, one cannot learn, one cannot heal if one is not communicating linguistically and culturally. Every one of us is a very unique culture of one, an individual that has cultural and social impacts that make us very unique. So when we're teaching someone or when we're healing them, that has to be a part of it. So cultural competence is a very important part of our approach. We use community health workers. I mean, we work with in collective impact with the community agencies, where we have folks who are from the community, who are bilingual, bicultural, who cross those social and cultural lines that can be an interface with the medical establishment in terms of reaching that child and that parent. So with the information technology, with the community, the cultural competency, the community health workers, creating a collective impact that can affect the kids. Well, we've been doing this now for 3 years. And for 2,000 kids that have asthma, and following them over 3 years, we have seen that their use of the emergency room has decreased by 36%. 36%. And their admissions, coming in after that whole night, coming into the hospital, has been decreased by 37%. So it can be done. It's something that if you come together in collective impact, and this is something that in United Way, where I'm a board member, we're very interested in seeing how we can bring together the schools with the clinicians, with the organizations, the CBOs, community-based organizations, how we can bring them all together and focus on things like learning and reading and health. So I think there's a role for each one of us, not just the educators in the room, but every one of us to come together and contribute from our point of view and our point of resource and make it happen. Thank you.
So thank you so much for that. I think it was a great idea of the collective impact and bringing together the community health workers, the IT, and the case management, and seeing how it really works. And let's hear from Delaney now and see what the Children's Health Fund is doing. I think it will be great to compare and contrast at the end.
Thank you. And first of all, thanks for having us here, and thank you for having this conference. It's so nice to be in a room of like-minded people where we're bringing together health and education and literacy and all of these really important issues that, as Liz said, they have to be tied together. It doesn't make any sense to deal with them separately, but that's what we tend to do, and I'm glad that I see these walls just breaking down, and I think it's a fantastic step. So thank you all for being here and so engaged today. Just to give you a little context where I'm speaking from, so I'm the Chief Medical Officer of the Children's Health Fund. That's an organization, we're a nonprofit that was started in 1987 in response to our co-founder, Erwin Redliner, seeing that there were kids in homeless shelters here in New York that just didn't have access to quality medical care. And so in response to that, they started the organization and designed a mobile clinic model with the goal to, if the kids can't get to the clinic, let's bring the whole clinic to where the kids are. The team, the labs, everything that they need, let's get it to where the kids are. And it's been extremely effective, and so it's been replicated. We fund programs all over the country. Now we have 25 programs. We're in 17 states, plus DC. And each program is different from each other. They all have the goal to bring care to underserved kids in a high quality way, but they're all designed slightly different because the goal is to meet the needs of that community and do it in a way that makes sense for those families there. But so we've been bringing health care to kids for a long time. We now, across our program, serve about 325 sites. About 2/3 are urban, 1/3 is rural, but about 62% of those sites are schools or early Head Starts, preschools, early education centers. So we've been working in schools for a long time, and the way our programs work is they may bring the mobile clinic to the school, but more and more through the years, they've been having programming in the school and the after-school programs, working with principals, working with even into the curriculum, and it's just been a natural evolution for us that the two have to go together, and I think I don't have to convince you guys of that. But what we've also learned over the 27 years is, there are some very clear health barriers to learning. Things like asthma, as Dr. Carrillo was just talking about. 10 million school days are missed because of asthma every year by kids. And that's not even counting the days that they show up, but they're exhausted and they can't optimally learn. Vision problems, hearing problems, all of these things, some of which are pretty easy to identify or to manage, or with good community and partnership programs, we really should be able to do a lot better, because if these barriers are in the classroom with those kids every day, how can they really achieve their optimal potential? And the more difficulties are placed in front of them, it's demoralizing, it takes away their motivation, takes away the fun from it. And we need to find a way to take away those barriers so each of those kids can live to their full potential. And the health barriers, it's just it's a chunk of the kinds of barriers they face, but it's a chunk we need to address because we know how to do it. And so, I know there are a few other pediatricians and healthcare providers in the room, and so, the obvious question for the rest of you might be, isn't that your problem? Aren't your people supposed to be screening and treating these problems? And yes, absolutely, and there are algorithms that we follow. Every kid is supposed to get a well child checkup every year and be screened for vision problems, hearing problems, anemia, things like that. But the problem is, especially when working with underserved populations, they don't necessarily come to us for that checkup every year. And as Sheena from United Way was saying this morning, there may be very good reasons that families aren't able to make that happen. So it's not a judgment on the families for not getting there, but the reality is often they don't get to us. And that's where a school partnership and a whole community partnership is so important, because for the most part, they do get to school. And the schools, currently they don't have the resources to do all the screening and all the management of the medical problems either. But if we work together, and especially with public-private partnerships, we can make that happen. So that's a new thing that we're piloting this year. We just started in September with 3 schools here in New York City. 2 are in the South Bronx, 1 is in Harlem, and you guys have the extreme privilege of, on your next panel, having one of our fantastic principals, Mr. Hernandez, who's going to talk to you a little bit more about one of the schools specifically. But the heart of it is screening, treating these health barriers to learning, and creating an environment of health in the schools, which is only possible with these very activated, motivated school partnerships that we have. So we're very fortunate. And so what we're doing is we're putting a full-time case manager in each of these schools and an extra mental health person to help this happen. And they work in partnership with the school nurses. And props to the city that 95% of our schools have full-time school nurses, because believe me, for working with schools across the country, that is extremely unusual. So not only do they need full-time school nurses, but they need extra support to make this happen. And so what we're doing is we're developing programs to do those screenings and then to work with community partners and other organizations to make sure that those health barriers to learning are dealt with. And just one quick example is vision screening. So this past month, we've been screening every single kid in those schools for vision. And across the board, 17 to 22% failed. That's every single grade. So you have to think about that from a couple of different perspectives. There are some standard school-wide screenings that are done, which is great that New York and most systems try to do that in the schools. That's a lot for them to take on as it is. But, kids become myopic or develop vision problems every year, not just if they don't come into school with it or not. But also, so many of the kids that we identified had been screened before, but for whatever reason, are not walking into the classroom with glasses on their face. So it really has to go beyond just the identification. The partnership has to make other things happen so that the problem is addressed. So what we're doing for Vision, for example, is we brought partnering optometrists in to do the ophthalmological exam on every one of those kids. And then we partnered with Warby Parker, who they're providing 2 pairs of free glasses for every single one of those kids who failed that screening exam. So the barriers are taken away from the families. There's no reason that kid cannot be in class with those glasses on their face and they have a spare. So, right now it's a pilot. We're developing it to show it works and proof of concept and dealing with the other health barriers to learning as well. But my point really is that it's doable, but it takes all of us to do it. It takes that partnership with the school, the teachers being engaged, working with the parents, the community physicians, and then the other organizations like asthma home visiting programs and the glasses providers and all of those different partners to make it work.
Wow, well, thanks, Delaney. That sounds like a really interesting project, and I'm glad to know it's up and running in 3 schools in the Bronx. And Tanya, do you want to fill us in on your work?
And I wanted to say, as a classroom teacher, there's so many students that I've had over the years who needed glasses, and it took months and months of getting the screening, supporting the family to get the glasses, and then sort of without fail, the first day they have them, there's an accident on the schoolyard and they're broken. So I love the idea of a spare in the pocket. Because sort of, or well, not in the pocket, right? In the teacher's desk would be great. But so I do come at this from being a classroom teacher and a school director, and just hearing it, it's so inspiring and gratifying to hear how many different sectors are really beginning to address these issues. When I think about myself as a beginning teacher, among the many things that I didn't know and couldn't do, one was that I really thought I had to solve every problem for every family and child that came, that crossed my doors. And I
had that problem as a pediatrician.
It's good to know. And I really, besides that I wasn't supposed to, I didn't have the skills. And so this is true, I've never worked at a school where there was a school nurse. So that definitely was part of the responsibility. So just having those pieces is really so exciting. I'm now in the very fortunate position to work with the team, the Reed NYC team at the United Way and Eastside House in Mott Haven, working on the Collective Impact Grant. So I'm glad you described Collective Impact so well. And I think our big question there is really thinking about in that community, what can we do together, and also what can each partner bring that really is highest leverage, right? So it's thinking about, as families come into contact with different service providers, both what's the highest leverage piece that provider can offer, and also how can we make sure that all the providers know what else is available. Right, so that as a school, when we have a family come in and we realize they need support with housing right now, that we know exactly who can hold them. I've done a lot of work in community schools, and one of the foundational principles there is that every child is known well by some adult. But that doesn't mean that adult is responsible for meeting all of the needs of every child, but that every child is held. And I think when I think about what we're looking for, what we're hoping to achieve in Mott Haven, is that every family is known well by some organization, right? Hopefully a person, that there's relationship in that organization. And not that organization is going to be able to solve all the problems, but that we can actually be proactive and reach out to other organizations. And I think about, that in schools, when parent conferences or family conferences are coming up, teachers know something about the health of the family and the child just in that moment. And there's not often a good communication system set up to say, I think something's going on. When it's crisis, there is, but the early signs. And just to speak to one of the the really amazing pieces of work that happened this summer was a summer program, the Once Upon a Summer in Mott Haven this summer, which was pulled together by an amazing group of folks, and I think really exemplifies some of the power when organizations collaborate. So there were many pieces that made it super successful, and one was that the schools worked really collaboratively with Eastside House, so that students, and that the schools really identified what students needed most, right? So we targeted kindergarten and first graders, had a strong program provided by Read Alliance. I know Kelly's up there. Really targeting what teachers felt the students needed, that was gonna prepare them for the next year. And we have a number of students who were slated to be held back. I think 6 students who were slated to be held back, but because of their participation and success in the summer program, were able to move on to the next grade. It was also able to be a full-day program, which meant that many more families could participate because of the work of Eastside House. And they made it a seamless day so that the afternoon was enrichment, but also pulled on the literacy pieces. And there was a parent support component. So I'll stop there.
That sounds great, and it's a very concrete example of something that happened literally this summer and really impacted many children, but 6 very specifically. The work that you all are doing is admirable, and I think one of the things that's so difficult is that these collaborations between community organizations, health institutions, educational institutions, they don't occur without effort. I mean, it takes a lot of hard groundwork to get these things up and running. And I'm wondering if each of you can speak to a key element or critical component that made your collaboration possible. What was it? So if other people in the audience are interested in replicating something that you're doing, what was it, that aha moment or that key thing that made your summer program happen, made your asthma initiative take off?
The first, I think, and the most important factor is building trust. One can't just come into another institution and say, well, look, let's do something together. Because everybody has their responsibilities, their commitments, their funding problems, and 1,000 other things. So there has to be a base there. There has to be, for us, being in northern Manhattan, which is, is an area that is bound by the rivers and is narrow, and there's a finite number of community agencies, organizations, institutions. There was Alianza Dominicana, Isabella Geriatric Center, Dominican Women's. I mean, you're all in the same neighborhood. So it's an important part of being part of a neighborhood, knowing each other over the years and having that trust. Basically, an example, a program that I did many years ago when I was at Harvard in the Harvard School of Public Health, it was amazing. I mean, you had the Harvard hospitals, one side of Longwood Avenue, those of you that know Boston, and then on the other side, you had the Mission Hill projects, which were very poor, Black and Latino, and you had in the Mission Hill projects, you had infant mortality rates like in Bangladesh, and across the street you had some of the top technology in the whole world in terms of taking care of kids who are sick. So it just didn't make any sense. And myself and my team, we basically spent a year getting to know the leadership of the Mission Hill tenants organizations. Dining together, spending time together. When there was an interest in learning more about asthma, for example, bringing in experts to speak about asthma to the tenants groups. So building that trust over a year before we began to start talking about, well, let's develop some community health workers, let's develop some peer educators, mothers in the projects who have had one baby and succeeded, and now they can be taught and work with a team to learn how to be a peer support to mothers who are younger, first time around, and who are at risk for many different reasons. So it takes time, it takes building trust, and it's important to be neighbors, people that you know, people that you've been around with for a while.
Great. So trust, definitely. Delaney, what would you like to add?
I definitely agree. I think for us, for our mobile clinic programs across the country and also for our school partnerships that we're piloting here now, I think one of the keys that we have learned is finding the right partners that really have a mission match that aligns with yours. Because we've certainly had programs or sites across the years where we'd have a mobile clinic, we'd set up the relationship, they'd say they wanted us to come, the neighborhood would make sense, the kids had need, there was access barriers, we'd bring the mobile clinic and we'd see, a couple of kids a day. And and we'd say for a few months, we'd try to have meetings, we'd try to make it work, but ultimately, sometimes it happened where we couldn't continue to use those resources with so little use. But so I think, and we chose our schools here for the pilot programs extremely carefully. Obviously, we wanted to pick the neighborhoods with the kids with the highest needs that we were trying to target anyway. But especially with the demonstration project, we needed to find principals that totally got it. They were invested in making it work. And especially with new partnerships, it's not all going to go exactly as you planned when you sat at the desk and first figured it out. So you want to find partners that are flexible, they're motivated, they're ready to get dirty with you and just figure it out and adjust and redirect when that needs to happen. But I think that mission match and that enthusiasm and that real buy-in into the program is really key to making it work.
Okay. So it sounds like trust could be a foundational. You can't get anywhere without the trust, but then you also have to have the mission match and that relationship ongoing and revisit the relationship as it goes. It seems like that's been part of your experience, which is also a key for anyone trying to replicate something like this. Tanya, what do you think?
Yeah, I would agree with all that. I would say, it's really figuring out how to play to the strengths of what all the partners are bringing, and also to really, I think this is what you were saying, but that the families and students are one of the partners. And so to make sure that we're listening to what their needs are, what their desires, so that it's not just organizations figuring out what seems to be most needed.
Right, letting the family voice be strong enough so that the organizations can listen to it, right? And everyone have those open ears. And I noticed your comment in your first minute speaking and also your answer here. I love that idea of playing to everybody's strengths, that not everybody has to fill every role, but really leveraging people's strengths and qualities to best, because that takes our limited resources, because let's face it, we have limited resources, and maximizes our impact. So as we start to plan and look with partners, that's something that you're consciously looking at, and I think that's a very important piece to it. So it's great. We've talked a little bit about this already, but I'm wondering if we can share maybe one real-life challenge that had to be overcome to make your community-based approach work. So let's talk about a real-life example or a real-life challenge. Maybe we could reverse the order. Tanya, you want to start? Sorry, I didn't mean to hit you with that.
That's all right. I don't know that this is a challenge in the partnership, but it's one of the things that I keep thinking about. It's related to health,
Sure.
so I'm just going to go there, which is around attendance, right? So we have this terrific program set up, and for all the reasons why families sometimes don't get their children to school, some children don't show up at summer programs. We were able to track the results really carefully from this summer program, and there was, not surprising, I think, to anyone, a very high correlation between students who made tremendous progress in a short, intensive summer program and students who made less or no progress, and their attendance. And that's where, so just thinking about just that
That's
piece,
a real-life problem.
That's
right
a
there.
real-life problem. And when I think about playing to strengths, I love the pediatricians giving books and modeling. I have to say, as a reading teacher, I get a little nervous about people teaching too many reading strategies who aren't trained to teach reading strategies. And what I think can be really powerful is the role that doctors can play in attendance. So I've taken my daughter to the pediatrician a lot of times and gotten a lot of books, which is, she has books, but she loves getting a book at the doctor. That it works very well. And I've not had a pediatrician ask me how many days of school she's missed. There's sort of a general how's her health,
Right.
but not how many days of school has she missed. And I'm guessing that lots of families have that experience. And there are many families, especially I think in preschool and kindergarten, where there isn't the sense that every day matters. There is that sense for the teachers, but that I think just that question could open up a whole thing. It seems like a perfectly healthy child, but she's missed 10 days of school already. Like, there's a place to intervene.
Yeah. Delaney, maybe you could follow up on that. I wonder if that's
Sure.
something your mobile clinics
Well,
regularly ask.
I mean, it's a great answer. I think that my answers would have been time and money, and the money and resources, that's kind of obvious, so we'll set that aside. But I think time is a really big deal, and from the provider standpoint and also from the school standpoint, it kind of comes at your question too, because anytime you see a kid in the clinic, how long do you have with them? Do you have 7 minutes? Do you have 15 minutes? What kind of a visit is it? We're lucky that on our mobile clinics, because we get so much private funding, that we can, if we have a kid who needs the hour-long visit, we can do that. Mm-hmm. It's a luxury we have that is unusual. But even so, there's so many things that we're supposed to fit into a single visit at this point that even literacy and Given the Book and all of that, it's hard. And even all of these health screenings for the health barriers to learning, it's hard to pack it all in there. Because I could show you, the questions we're supposed to ask just to screen for asthma. And I can ask them to you quite quickly, unless you say yes to any of them. In which
then
case,
you're stuck
then
for
we
10
have a lot to talk about. And especially when you're dealing with underserved populations, there's a lot of yeses. And we're also screening for food insecurity, housing problems, psychosocial problems. There's a lot to fit in. And so I think just time is tricky. And going back to what you're saying of matching the needs of your families and patients, that's just the agenda I'm walking into that visit with, and they have a whole other list of things they want to talk about. So I absolutely think we should all ask that question. We're supposed to all ask that question, but there's 150 things we're supposed to ask at every visit, and it's hard. And I think on the flip side, and I'm sure Mr. Hernandez will say something similar if asked the right question, but there's so many things that the schools are supposed to take on and do and provide for these kids. It's completely overwhelming. And so then we're coming in and saying, oh, can you do health screening too? Can you work that in? Can we work into our curriculum, to your curriculum? And that's a big ask. And, we're fortunate that we've found schools and partners, and people are starting to understand the connections and why these two things do have to happen, and how improved health can lead to better educational outcomes and things like that. But I think aligning on the goals are important, because what's going to bring schools and educators, what's going to give them buy-in to help us do the screenings, is if we can show that doing those screenings and providing those interventions also helps them achieve the goals that they're being measured by in the testing and graduation rates and attendance rates. So I would say time is tricky.
Okay.
One of the things that is not always too apparent can be a real challenge is beware of the experts. Beware of the experts. And I go back to, I was just finished my training in a very, well-known hospital, one of the first Latino doctors coming out, going back to work in the community, going to work in a community health center, and all the expectation, we got a Latino doctor, this is wonderful, and I felt like, well, here I come, and I'm going to do it, and there I was, and day after day, seeing my patients with diabetes, with asthma, blood pressure, and see them again and again, and they weren't getting much better. I not taking the medication, not seeing any results, and after 6 months, 8 months, what's going on here? And one day I looked in front of my desk, Carmen, who was my MA, medical assistant, and she's she basically has just a high school degree and from the community and lives there, and my patient, whom I couldn't figure out, was there talking with Carmen, and they talk, and they're chit-chatting and laughing, and I thought, Carmen, tell me what's going on with Mrs. Valdez, and well, her daughter is went back to Puerto Rico, and now she's alone and doesn't have the support and doesn't have the money, doesn't have understand the medication, can't read the medication, and on and on and on. And my goodness, she knew so much about this patient, things that were totally important to the care of the patient that I couldn't do anything with all my knowledge and all my degrees and all my whatever, couldn't touch it. So the expert was powerless. it's so important to involve in anything that we do, to involve the grassroots, to involve the people themselves who are impacted, the parent, to just realize that, be a little more humble about our expertise and really focus and learning from those that are right there on the ground.
No, I love that answer, because usually the people on the ground actually know the answer as well. They just need help in getting to the answer, and that's where the collaboration and the work can get. They know the problem far better than any expert. They're living it. So I think that's very useful kind of for the audience, the real life challenges of how we get these community collaborations in place. I just wanted to reach back to literacy a little bit. So, Reach Out and Read is really a model of integrating literacy into health promotion. But as we said at the beginning, health is important on its own. Education is important on its own. We love to weave them together, but they both need to be equally strong. I always like to think about school readiness as a three-legged stool. A very old analogy, but you know what? It works better for me than a Venn diagram. It's too fancy. And the three legs of the stool are healthy families, early learning, and healthy children. And if I'm going to sit on a three-legged stool, I actually would like those legs of the stool to be connected, sort of like this table is here. That's a lot more stable with the connection at the bottom than if they were all separate. And my other this is from my grandmother. What's the most important leg of a three-legged stool? The one that's missing. So we can't have any of those missing. We have to have all three components to get our children healthy and ready for school. And so with that, I'd like for you each to think about how your unique approach builds on the relationship between health and literacy and makes those connections. So maybe we'll reverse.
Well, I think that health literacy is very, very important. I just noted that Tony Tassi is going to be in the next panel. He's someone who, with many others, have been working on the issue of health literacy for so long. And it's not just learning to read now, but it's a lifelong, the ability of an individual to understand the instructions, understand the education, understand what has been taught at the school, what is being taught by the physician, by the nurse, by the caretaker. If one has literacy challenges, numeracy, meaning like ability to read numbers. I mean, look at a label. I mean, trying to read a medication label is harder than reading an airplane ticket. I mean, it's just looking at the numbers, and it really it's a challenge for anyone even with a college degree, a graduate degree, to understand medication labels. Never mind food nutrition labels. It's really hard. So I think that literacy is so important for health in so many ways, and at the most obvious level of being able to understand the instructions of what you need to do to get better.
Yeah, it's okay. Wonderful. Delaney?
I think it's all about the interlocking cycles of poverty, of health, of educational achievement. I mean, they're all the chicken and they're all the egg, really. And if you think about, I don't know if you've ever heard of the term toxic stress, but there's a lot of research in, what's happening in a woman while she's pregnant affects the brain development of that child. And what happens in that child's life and in their environment and their stressors affects the way their brain grows. You can see differences on PET scans and MRIs in the way, even their anatomy of their brain, their genetic expression, their physiologic biochemical set points. All of that is changed by what they're exposed to in utero and in the early part of life. That even affects their ability to learn, their ability to read faces of other people, their ability to self-regulate. And it just is all so tied together with, so then what is mom and the family dealing with poverty that's making them so stressed or so unsupported, that then is affecting the future generations of the family? What is that child walking into school already held back by, these health problems or these poverty-linked problems or whatever's going on at home that night, or is there dinner there? They're all so tied together that we can't even think of them separately. So I think we have to try to figure out solutions that hits all of those points all together. And as you so eloquently said several times, nobody can do all of that. But we have people who know how to do all sorts of little pieces of that, and we just have to bring it together.
Wonderful, wonderful. Tanya, you want to wrap it up?
Yeah, so I have two thoughts about it. And one is, when we have a community where 1 in 10 third graders is reading on grade level, that's not a healthy community. So however we're defining health, right? That's not a healthy community. And then the other piece is, I think, from my time in the classroom, I see, and my own life experience, that I really think when we are learning, and I don't know if there's research to support this except that, but when we're learning and when children are learning and succeeding, they are healthier, I think, in mind, but also in body. I think the connection works both ways. So I think there's also, as we're doing all the outside of school work, to keep thinking about how we make sure that classrooms are places of joyful learning, and that teachers are supported in all the ways they need to be to provide that, we end up with healthier children and healthier communities.
Well, that's a wonderful way to end, and I think all three of you bring unique experiences of building those community collaborations and weaving together health and education as it needs to be, because it really does come down to that community level, and that's where the work that you're doing is so important. So I really appreciate you all being here today, and of course we thank Reach Out and Read, and I think that's it. Oh, sorry, group questions. My bad. Can you tell I want to get off the stage? No. So anyone from the audience, please have questions for our experts. I think we have to wait for a mic here in the front. This gentleman here.
That's an assumption.
Yeah, sorry.
Good morning.
Good morning.
There was a recent survey of a community in upstate New York of pediatricians from a group that was really interested in the multi-domains of school readiness. Mm-hmm. And what they found was that pediatricians really had, and I'm trying to be fair on this, less than optimal understanding of the multi-domains. And two, they were not using psychometric valid instruments in their assessments. Can you tell me what the role of pediatricians is in looking beyond simply the health, but looking at cognitive development, language development, the social emotional development as well?
So fascinating. Maybe you start and I can.
Sure. I'm disappointed to hear that, and I hate it when I hear things like that, because as part of that group, we should be doing better than that. And there's training for us to do it. The things that we're supposed to know how to do are always changing and advancing, but it's our responsibility to keep up with that training. We should be using standardized tools to assess milestones and socio-emotional development. We should be asking parents if their kids are missing school and zoning in on that. I have no excuses for you, because I totally agree it should happen. It's hard to fit it all in because, like I said, you have a limited amount of time, and I think it is getting to the point where there is too much to fit in. We're trying to figure out better ways to do that, having, nurses or paraprofessionals do some of the pre-screening so that then the provider visit can still be focused enough to deal in what was identified, and, other more creative ways to utilize staff and everybody's time, the patient and parents' time as well, because they don't want to be the doctor an hour and a half either. But I think we should do better than what you're describing. I do.
Yeah, and I would follow that up. The American Academy of Pediatrics does have recommended developmental screening criteria that's actually prior to kindergarten. Children should be screened with a valid developmental tool at 9, 18, 24, plus or minus 30 months. And that depends whether you see them at 30 months, and also an ongoing surveillance developmentally across all 5 domains of child development. Again, time is a constant pressure. I think also one of the things that it's interesting as I work crossing sort of between health and education worlds, school readiness as a term is not necessarily something that physicians use or think about. I do, but that's kind of where this unusual little place I ended up. So oftentimes, one of the things that makes our collaborations difficult and makes our communications hard is we often use different vocabularies, and that's something that we can work on, and all of us being here in this room today helps us work on that and understand differently. But school readiness as a term means different things to different people. So I also wonder, how that struck even the survey. And it's a fascinating, I'd love to learn more about it. So if you want to meet up afterwards, you can tell me about it, and I'd love to hear what's happening upstate with that. Any other questions?
We were so complete.
I know. Or they want to get on with the next panel, either one. All right. Well, thank you, everyone, for your time. And again, thank you, panelists.